Hello, everyone. Today we are going to discuss sub notes. We're gonna first, I'm gonna first introduce everyone from of my amazing colleagues who are gonna help us to explain more about sub notes. And after that, we'll go through some introduction. Then I will leave you with my colleagues, PGY1 and PGY2, and Dr. Higazi, who is an attending at the University of Louisville, who will elaborate more. I just want to make sure that everyone can hear me okay. If you hear me, you just raise your thumb up. Is it okay? Everyone can hear me. It's okay. So welcome everyone. I'm gonna share my screen right now. So everyone can see my screen, right? So we are gonna talk today about sub notes. We will have two of my amazing colleagues, Dr. Rafiq al-Bulgawi, who is a PGY1 internal medicine resident at the University of Alabama, and Dr. Ahmed Mwafi, who is PGY2 internal medicine resident at Rutgers Trinitas Regional Medical Center. And then we will conclude this lecture with our mentor, Dr. Muhammad Higazi, who is assistant professor at the University of Louisville. I'm gonna just in brief give you some introduction about what's subnotes, what does it mean. So subnotes, it's important, I believe, for everyone who is gonna apply for US residency, because this is the format we use here to dictate any patient notes. Why it's important and how to review the components of the subnotes and the challenging facing every one of us or every one of the residents once they started their residence. This is our educational goals, and we will ask our colleagues to give us some tips about how to dictate better subnotes. And at the end, we will go through some more details to know the best practice, how to write the best subnotes. So why we should use these subnotes? Usually, I will start with what subnotes first. S stands for subjective. O stands for objective. Subjective means that this is the information you get from the patient. Objective means the data you can measure it, like labs, like physical examination, this stuff. Then A stands for assessment and P stands for plan. This is the plan for your patients. So why we use this subnotes? We have usually, first I need to ask everyone to mute the mic, please. Hello? I'm asking everyone to mute their voice. Thank you. So we have a lot of information about the patient and the information we need to use and we need our colleagues to know about the patient. But by time, this information get more and more with introduction of the electronic medical documentation and the electronic medical record, which may be challenging for your attending or your colleagues to follow up your note or to follow up what are you doing with this patient. So this is why it's important. This is why it's important for everyone to follow the same format. So that this is the importance of the subnotes. It's a way of organization of your note. You know what to do with your patient, what you need to do first, second, and after that, what you need to do. After that is standardization. You have standardized format for this. Everyone can follow, which make it easy to communicate with your colleagues or your attending. You know the stuff, you know where you can get the information you need from this patient. So this is the main line why we need the same format, why we need subnotes. We went through this components before. subjective, SOABP, S for subjective. This subjective information, you get this information from the patient. He's saying, I have some pain on my belly. This is the subjective. Objective, something we can measure, something about numbers, about physical findings you can see in your patient. So you need to know the vital signs and physical examination, so on. We will go through this in details after with our amazing colleagues. A stands for assessment, and as we said, you should have like preliminary assessment or provisional diagnosis, main provisional diagnosis, and what other problems this patient might have, other differential diagnosis. And according to this assessment, you will figure out your plan and you write everything in your plan according to the order of your problem in the assessment part. So this is just overview, and I will ask Dr. Rafi, our amazing colleague, to start from here and go from here and to give us some more information about the challenges he faced during his PGY1 this year. I'm sure he has a lot of information to share with us, and he will go from there. Dr. Rafiq.
Hello all, how are you?
How are you?
You all can hear me well?
Yeah, fine. Thank you for being with us.
Okay, thank you, Mustafa. Thank you, Dr. Higazi, for having me here today. Thank you for everyone coming. I'm Rafiq. I'm a PGY1 internal medicine resident at UAB Huntsville campus. I just started my residency a few months ago. And I was asked to talk with you guys about some of the challenges we meet here as interns for the SOAP notes. So basically, just a quick introduction. I'm originally from Cairo, Egypt. I graduated from Cairo University, and then spent some time in residency at Cairo University in oncology. Then moved to the States to complete my exams, do some rotations, and I spent almost a year and a half in doing clinical research at the University of Louisville in Kentucky. Then I moved right here in Huntsville, Alabama for my residency. So most of us are not very exposed in our home countries or whatever different clinical experience to the EMRs and what it has to do with our clinical practice. But in real life, this really has more than maybe 60% of our days that we have to write our notes. But this is maybe the main theme of communication between physicians in the hospital. Still, you can touch base through direct physical communication, but mainly like the official and the most way that you depend on your communication is the notes. So as Mustafa mentioned, is notes mainly, it should talk about subjective, objective assessment and plan. So for the subjective part, usually we go directly just to talk what's going with the patient today, what the patient want to mention, any new complaints, any new events, progress notes, like you see what's going on overnight, just to mention maybe a quick liner, one or two, just 2 lines describing what's going on today with the patient. We don't take another full history again because you already have admitted this patient. So you just give a quick liner, what's going on today with the patient. And you move quickly to the objective. And again, as Mustafa said, objective is about your physical exam, lab findings, microbiology, diagnostics, any imagings have been done since patient's admission. But to be honest with you, in real life, we don't do the objective every day because, like, for example, patient has been admitted for maybe COPD exacerbation. So he came already with dyspnea, shortness of breath, and all other symptoms. So You can hear maybe lung wheezes on his exam. You might not mention this every time, but this is very essential on your initial admission. You need to mention this patient is wheezing on your physical exam. But maybe later on in real life, because maybe you're writing more than 10 notes a day, there are some, I'm not sure how many of you have already done rotations, been exposed to the EMRs here. There are kind of things that you just like do a copy, like not a copy, it's called an auto text that auto populates specific templates for physical exam and for labs, for vitals, and you just populate it into your chart. So usually physicians, residents don't put a lot of work or time on this part, and usually we go directly to the assessment and plan. And if I would give maybe a piece of advice or something that I've been challenged for starting my residency, that anytime you go to a rotation doing research here in the US, you need to read a lot of your attendings notes, other residents' notes, to get an idea of what's going on. And for example, in my research, I was doing a clinical research, so I had the opportunity to read a lot of notes every day. So when it came to real life doing my residency, this really helped me so that I can at least have a baseline how physicians put their notes in. So I would encourage each and every one of you who's doing rotations or doing research, put a lot of weight on reading the notes, just having an idea how they put things in order, how physicians think about the assessment and plan, how they put things together, because this would really help you later on. Because we are not really used to this kind of experience in our home countries, and we don't use EMRs in most of the part over there. So I would believe this would really help. So again, to put things, and I think Mustafa, correct me if I'm wrong, Nabil gonna talk about the assessment and plan, right? You want me to?
Yeah, Nabil Muafi will go from the objective part and so until the end, because he seems more comfortable.
Sure. Yeah, and I would really this is my experience as an intern, and I'm sure that Dr. Muafi would have more input into this, and absolute Dr. Higazi as well. But the thing is, usually in residency, I mean in your internship year, don't expect someone to sit beside you, tell you that, okay, point number 1, you do this, point number 2, do that. No, usually it doesn't go like this. You are just on the front line. You start. You need to start working on your notes. So it would really help you if you have an idea. And this really this lecture would give you a kind of idea of how the SOAP notes go here in the US. But I mean, it would really help in your rotations to have an idea how the EMR goes, how the residents and physician put their notes. And mainly for the subjective part, if I'm talking about this right now, we don't repeat everything. Like usually what I do in my notes, I just put a one line today, what's going on. So maybe the patient has been on maybe high flow nasal cannula yesterday. Today he's down to 5 liters. He's complaining today of constipation. Tomorrow he's improving. That's just a quick one-liner of what is the patient complaining of today. And again, no one really would sit beside you as an intern, tell you every and each thing, because things are really busy, and your upper levels are still busy with admitting other patients. Things get really busy in real practice. So you would need some of your own experience and your own input when you start your internship year. And I think this is something that we need to get to have everybody who's getting into residence to be prepared for this.
Cool. Do you have anything to add? I will keep the questions from everyone to the end of the session after everyone does his part, so that we are not repeating the question. Do you want to add something right now, or we can wait for questions?
I think that's good for now, but let me know if you want me to stress on something specific or.
We will start asking after Dr. Hijazi finish his part. So for everyone, I'm including here for this presentation the detailed points of SOAP notes. But what we are gonna do here, I'm trying to ask our colleagues to share us their real experience, real life experience, not going through everything, because most of this you can see it on the internet, you can read it on the websites. So I don't like to just waste some time with go through everything. This is something you can read it through this presentation, and I can share it with you and go through the video again, and you can find even more impressive presentation more than this. I mean, from the perspective of the detailed points. But we are trying to use the help of our colleagues to know how is the real life goes and what the challenges they had. So thank you, Dr. Rafi, for sharing us this, and we will wait for the end. So if anyone has any questions. Right now, we'll go with Dr. Muafi, who is BGY2, and I think he has some more items to elaborate and talk about. So he will go from the objective part here. So, Dr. Muafi, are you with us?
Yeah, Mustafa, how are you doing?
Hi.
Can everybody see and hear me okay?
Yeah, everything is okay.
All right, so good afternoon, everyone. My name is Ahmed Muafi. I am a PGY2 resident at Trinitas Regional Medical Center, part of the Rutgers Hospital healthcare system. I too grew up in Cairo, Egypt. I graduated from Ain Shams Med School, class of 2015. I did 1 year of research in Louisville. That's where I met Mustafa, Rafiq, and Dr. Hijazi. And currently I am in New Jersey working at Trinitas. So when Mustafa told me that he wanted me to take part in this talk about notes, it's a very, very important topic, honestly, and it's something that most of us IMGs completely forget about or don't really pay much attention to before we get matched and get into residency, which is, again, a grave mistake, because like Rafiq said, Dr. Babawi said, I was on call July 1st, my very first day of residency, I was on call. And we had a lot of admissions, of course, and I had no idea what I was doing. Like I was reading notes on my patients that I inherited from everyone, like all the other residents who finished the floor rotation on June 30th. And here I was, July 1st, having my own patients and having to do admissions. I was on call, so I received sign out for all the patients in the hospital by 4 p.m. and I had to keep an eye on them until 9 p.m. And I honestly, for the first few days, I had no idea what I was doing. It's not that the note was difficult to write, no, but I didn't really know what was important, what was not important, what to document, what not to document, when to document things, essentially. So I agree with my colleagues here that it's very important for us as IMGs, because we're not really familiar with the healthcare system here. We're not really familiar with the MRs. So this is one of the biggest challenges you're going to be faced with as an intern. Especially when, like Rafiq said, you have a lot of patients on your lists and you have a lot of notes to write and you have a lot of things to do and you don't really know how to organize stuff or put them in order. So going on, moving forward, so we have the objective part. So the objective part of the note it's not the most important part of the note, but it is the one that is built upon. Like Rafiq and Mustafa talked about the subjective part. So the subjective part changes daily, on daily basis. Every day you walk in, you see the patient and okay, so the patient today is complaining of this and this. He says that this is better, this is worse. This is somewhat of a subjective information that you get from the patient. As for the objective part, this is where you as a resident come in. This is where you as a physician come in. So the objective part means everything, every objective evidence that you have on the patient, starting from your vital signs and physical examination, and then going through his labs, diagnostic tests, whatever imaging you have, and then ending with the assessment and plan. All right, so objectively speaking, I would also give a piece of advice, and I see that I saw that a lot as an intern, and I do see that now as a second year. The objective part, yes, a lot of EMRs allow you to auto-populate or copy forward your notes from the previous day, but it is important, especially as an intern, when you admit a patient with a certain problem, to know exactly what's the major complaint and what's the major objective sign you're looking for. So for example, Rafiq used an example of someone who is in COPD exacerbation. All right, so you're admitting a patient who is wheezing initially, and on your on your objective examination on the very first day, the patient is wheezing. So on daily basis, every day, you will listen to the patient's chest, because that would tell you, regardless of the labs, the imaging, whatever, your objective assessment of the patient as listening to his chest, his or her chest, would give you an idea whether or not your management is proper or whether the patient is improving. Because let's say that a patient is hospitalized for COPD exacerbation and has been in the hospital for like 5 days. And on day 5, you're still hearing wheezes. Something is definitely wrong. Something is not going right, because the patient should not be wheezing 5 days from admission. So that means he's either misdiagnosed or he's being mismanaged. So that's why I would say that it's not, of course, it's not time efficient to focus on a full physical exam every time you see the patient every day, but at least stress enough on the important parts. Like if it's a cardiac patient, make sure to listen to the heart. If it's a chest patient, make sure to listen to the chest. If the patient is coming in with sepsis, infection, whatever kind of problem the patient might have, just prioritize 1 or 2 systems that you have to check up on every day, and be sure to document the improvement or the progress of this system, because that would give you an idea about how well you're doing managing your patient. So that's for the objective part. Now, as physical exam, again, it's not time efficient to perform a full physical every time you see the patient, especially if you have a lot of patients on your note, but you do that on admission. So you're admitting the patient, you're seeing the patient for the first time in the ED, you have to do a somewhat full physical examination. And I understand that this idea might be daunting to a lot of you guys, because I'm going to perform a full physical exam. It doesn't really take that long. Of course, when you're starting, you're still getting to know exactly what you're doing, and you come up with your own rhythm, essentially. You don't have to follow everything that's textbook. The thing that you will find out once you start working is that everyone has their own style, and you have to develop your own style. Whether you inherit that from someone, whether you copy that from someone who's taught you something, or you combine a lot of things that different people teach you throughout your residency, you eventually come up with your own thing. So physical examination, you can have your template, you can read someone else's template, you can come up with what's important, what's not. And as you progress in your residency or in your career, you will find out what exactly is important and what is not, what to focus on and what to actually ignore or not really pay much attention to. And so you will perform the full physical examination on admission when the patient is first seen, but then day after day, you only have to focus on what's really relevant. Like, for example, the COPD exacerbation guy. Initially, you perform a neuro examination, and everyone knows how difficult and long a neuro examination can be. So you're not going to perform a very extensive neuro examination. After all, this is an IM residency. This is not a neuro residency, and the patient does not come in with a neurological problem. But generally speaking, does the patient have any motor dysfunction, sensory dysfunction, cranial nerve dysfunction, any problems with their reflexes? Essentially, that's what you're looking for. So you assess that daily. Assess that on the first time, but then daily, you don't have to reassess that. You can just make do with the subjective part. You can just ask, so sir or ma'am, do you have any weakness today? Do you have any problems moving any of your limbs? Do you have any numbness anywhere? That's a subjective part. So you ask the subjective question and the patient says, no, not really. Admittedly, that's patients are not the best historians. Sometimes they're not very reliable. A patient will tell you that nothing is wrong with them, while objectively you see something is off. But this is a bit more complicated, and this would require a bit more experience for you to pick up on stuff like that, which you will gain with time. So again, just every day you examine the concern system, the thing you're following on daily basis, be it exacerbation of COPD, CHF, edema, pain, infection, tenderness, whatever it is, you just focus on that sign and follow it on daily basis. Then comes the lab work. So lab work, you got the complete blood count, the comprehensive metabolic panel, whatever labs you're following on potassium, creatinine, CPK, blood alcohol levels, urine toxicity levels, whatever it is you're following, you trend those. And that kind of goes goes along with whatever you're trending for the patient. The most important part of anything is you do not take a snapshot because that could be misleading. For example, if you encounter a patient and you take a look at his white blood cell count, like you are covering a patient, you're seeing the patient for the first time today, and the patient has been in the hospital for a week, and you take a look at the CBC and you find that the white blood cell count is like 15. Okay, 15 is above the normal limit, so is this patient septic? But you have to look at the trend, not just the snapshot, not just the number. If you have a white blood cell count of 15, what was it yesterday? What was the previous count? Maybe it's coming down from 30, maybe it's coming up from 2. So that really gives you an idea about what's going on. So you don't look at just the number, you take a look at the trend as a whole. Of course, it makes it easier if it is your patient and you've been following the same patient every day, then you don't really need to go over the entire chart every time. But for example, if you're on a weekend and you're covering patients that are not yours, you have to take a look at the entire picture, the bigger picture here, because just a snapshot, just a single value can be very misleading. So I think this would be it for labs. Same goes for imaging. Like radiologists say that in every report that you would find on any chest X-ray, CT, head CT, whatever it is, you will find the radiologist commenting on whether or not the patient had a previous CT or a previous chest X-ray, a previous study to the one that you are reading right now. Because again, the radiology is trying to look at a trend to see, for example, they find a nodule in a patient's lung. Has this nodule always been there? Has it been getting bigger? Has it been getting smaller? Is it a new finding? So also checking trends is also important for imaging as well. Now on to the like, in my opinion, the most important part of our note, which is the assessment and plan. And the reason I'm saying it's the most important part, not that it's the part that everyone looks at, because everyone should read the entire note, especially residents. But if we're talking frankly here, attendings, and Dr. Hagazi can concur on that. When you're, for example, consulting someone, consulting hematology, oncology, consulting pulmonary, consulting cardio, consulting anyone, the first thing that the attending's eye is going to go to in your note is the assessment and plan part. Like they're not going to give much attention to the subjective, objective. They're going to read the labs or whatever workup has been done to the patient, and they're going to read on your assessment and plan. So what do we mean by assessment and plan, and why are they coupled? So as the note goes, the flow is, so this is subjectively, so the patient, let's talk about the admission note, and because the progress note is kind of like an imitation of the admission note as you go along. And in my humble opinion, I think that the admission note is the most important note you're going to write for a patient. Because if you have a very good admission note, you have a very good basis on which you're going forward, progressing day to day. So the first thing, subjective part, the patient presents in the hospital with this complaint, shortness of breath. And now you kind of tell the story of the history of present illness. For how long has this been going on? Does the patient have any associated symptoms? Did the patient have anything like that before? Did the patient take any medications for it and whatnot? And moving along to the objective part, and then the assessment and plan. So your assessment is essentially your understanding of the case. So we have a patient coming in with shortness of breath. You do an X-ray which shows hyperinflation of the lungs, jet black lungs, and then you show labs that are showing, for example, an elevated white blood cell count, and you see on the vital signs part, the patient is desaturating on room air. So your assessment part is essentially your understanding of what's going on and you putting together everything. So it's not going to be like a 50-year-old male complaining of shortness of breath. No, this is not sufficient as an assessment. So yes, he's 50-year-old, past medical history of this, and that. Comes to the ED complaining of this, and that. On examination, this was found. On labs, this was found. On radiology, that was found. So essentially, you are now treating COPD exacerbation. So this is your initial assessment of the patient. And the assessment part changes as the patient progresses in their hospital course. So for example, you might be admitting a patient for COPD exacerbation, but then 5 days later or 4 days later, you discover that the patient has an underlying pneumonia. So your assessment is going to change. It's not just going to be COPD exacerbation. It's going to be COPD exacerbation superimposed with pneumonia. So it's dynamic, it's important, and it really shows what kind of resident you are, because the better your assessment, the better you're diagnosing the patient, the fitter your management plan is going to be. So it's kind of like a small paragraph encompassing everything that's known about the patient and your interpretation of it. So the patient presented with shortness of breath, a fever, an oxygen saturation of less than 90% on room air, and the CBC showed a WBC count leukocytosis of 15, and the X-ray showed hyperinflated lungs with patchy infiltrates on the right lower lobe, for example. So this constellation of symptoms and signs, as they call it, would most likely point to pneumonia. Yes, the patient might have history of COPD, and this might be a case of COPD exacerbation, but you cannot miss the signs for pneumonia. So this is what I mean by an assessment. Your assessment makes everyone understand what the patient is here for, and you're the one responsible for making that assessment. So, and it changes because I see a lot of residents who do that, who copy forward their notes. They change the plan part, they change the objective part, but the assessment part, they leave it the same. And this is a mistake because your primary assessment of the patient on admission might very well change as the patient progresses in the hospital course. It might change. You might have misdiagnosed the patient initially, but now you are treating something else. So the assessment part should change as well. You should keep an eye on that as well. Now coming to the plan part. So the plan is, what are we doing for this patient? And largely speaking, the plan part, there are two ways of doing it. And it differs according to hospitals, according to residents, according to attendings, according to specialties. There are the system-based plan or problem-based plan. What does that mean? So problem-based plan, which is the system that our hospital uses, for example, which means the patient comes in with COPD exacerbation. So the first thing on your plan is going to be the COPD exacerbation. That's the problem. You're going to title the problem and then write what you're doing about it. So on the other hand, system-based is going by systems: cardio, pulmonary, GI, genitourinary, neurological, you have it. Problem-based assessment and plan is, objectively speaking, a system-based problem list is more incomprehensive. It is less likely to miss something, but it is very long and very detailed.
شوية عندنا
to be extra careful doing that or coming up with that, because you don't want to miss anything. You have to be that super resident that does not miss anything on examination, in addition to the patient's past medical history. Again, a mistake that I did the very first day of residency was that I was focused on the problem at hand and I kind of forgot about the patient's past medical history. And you cannot do that because, for example, this patient coming in with COPD exacerbation and pneumonia, if we're going with the same example, let's say that this patient is diabetic and he has history of diabetes, but when he comes in, his blood sugar is 100. It's normal. It's okay. The guy's controlled. But if you forget to put that the patient has history of diabetes in your plan part, you have to list the patient's past medical history as well. Because if you forget, for example, to put the patient's diabetes or take it into account, and the patient is indeed in pneumonia and is indeed septic, a few days later, his blood sugar is going to be out of control. And you don't even have diabetes on the problem list. So whoever's going to read your plan is not going to even know the patient is diabetic and requires close monitoring of their blood sugar. So the problem-based plan should include the problems at hand, the problems that the patient presented with, and also the past medical problems and what is being done about them. Now, coming to the details under all the titles. So I'm not going to get into too much detail because that could take us some time, and I feel like I've been talking for a while now, but I'm almost done. So first of all, that's the problem, COPD exacerbation. So the first thing you should do is, why do you think this is a COPD exacerbation? So you include the patient's subjective complaint, your objective findings in the assessment part. So the patient is coming in complaining of shortness of breath. That's subjectively. Objectively speaking, he's saturating 85% on room air, and his white blood cell count is so and so. His radiology, his chest X-ray showed this. So this is why you're thinking this is COPD exacerbation. Now, the following that would be other things that would rule out other problems, other differentials. So let's say that you're not sure whether the patient has COPD exacerbation or CHF exacerbation with pulmonary edema or pulmonary vascular congestion, because they both can present with very similar complaints. Shortness of breath, and you would find that the chest x-ray has some infiltrates. It might be pneumonia, it might be CHF exacerbation. So you have to list why don't you think it's a CHF exacerbation? Be it the patient has no cardiac history, the patient is compliant with their medication, the patient says that the last time they'd seen a cardiologist was 3 months ago, whatever it is, you have to ask the questions that rule out other problems within the differential diagnosis. Following that, you will say what occurred to the patient in the ED. All right, so the patient came in with COPD exacerbation or shortness of breath. So what was done in the ED before the patient got to you? Did the patient receive fluids? Was the patient put on oxygen? Did the patient receive steroids? Did the patient receive any kind of antibiotics? This is relative and relevant information because it will, again, dictate what you're going to do. Because emergency medicine, of course, with all due respect to them, they are a different specialty and they look at things differently. They are concerned with the here and now, what they're dealing with the patient. For example, we run into a lot of problems because of fluid resuscitation, because the ED essentially goes along the ABCDE kind of algorithm: airway, breathing, circulation, when it comes to saving a patient's life. So if someone comes in, for example, with altered mental status, and they notice that the blood pressure is low, they bolus the patient with fluids. Normal saline, lactated ringer, 2 liters. The patient got 2 liters of normal saline in the ED. And then the chemistry comes out and the patient initially was hyponatremic with a sodium of 110. So now what we're dealing with is that's a patient hyponatremic and you gave the patient essentially 2 liters of salt and you have no idea what the sodium is now. I'm not saying that the ED made a mistake there. No, they were dealing with the here and now, but you have to include what was done to the patient in the ED because, again, a patient like that, you will have to fluid restrict. You will not start fluids on a patient like this. So again, what was done to the patient in the ED before you got to the patient, and now here's your turn. Here's where you come in as a resident. All right, so I received the patient. What are you going to do? What labs are you going to order? First of all, so do you want any more investigations? Do you want any labs? Do you want any imaging? What are you going to order for this patient? Number 2, medications. What are you going to be giving this patient? You're going to be starting antibiotics. You're going to be starting nebulizer treatment. You're going to be starting steroids. What are you going to do in terms of intervention? And lastly, who are you going to call for this patient? Are you going to call pulmonology? Are you going to not call pulmonology? Are you going to call cardio to rule out CHF exacerbation? Are you going to order an echo for this patient to rule out any systolic or diastolic dysfunction? So essentially, this is your plan. So first of all, why do you think this is the problem? Why this is COPD exacerbation? Number 2, why don't you think this is a CHF exacerbation, or why don't you think this is a pneumonia? Number 3, what was done to the patient in the ED? Number 4, what extra investigations you want to order for the patient? Number 5, what are you going to do to the patient in terms of medication or management? Number 6, consults. Who are you going to call for this patient? Does this patient need a higher level of care? And you go by that for every problem you're faced. COPD exacerbation, anemia, for example, history of UTI, history of hypertension, history of diabetes, history of dyslipidemia. No matter how many patients, how many problems the patient has, you have to enlist them all. Again, because going forward, this will be your admission note. And from day to day, you're going to be essentially copying forward your assessment and plan, changing or doing minor tweaks to the thing that to your initial assessment is essentially. So the patient presented with COPD exacerbation, his saturation was 85 on room air, now 95 on oxygen, let's say 6 liters. The following day, he's going to be 95% on 4 liters. The following day, he's going to be 95% on 2 liters. The following day, he's going to be 95% on room air. So this is how you track your progress of your patient and how effective you are managing your patient. And I guess that wraps up the assessment and plan part. I hope that I talked about everything you wanted me to talk about. I think you're muted, Mustafa. I think you're still muted.
We will go for Dr. Hijazi. Dr. Hijazi, are you here?
Yes, I am. Assalamu alaikum. How are you all doing?
How are you, Dr.
And good. Thank you, Mustafa and Ahmed and Rafiq for putting this effort. I think you all covered pretty much what I would like to say in this topic. The only difference I would say is when you are on subspecialty so the notes is SOAP notes specifically, his goal is to tell what's going on with the patients. That's why we call it progress notes. So what's progress, what's going on with each patient each day, and everyone, consultants and primary, should look at your note as the resident and know what exactly is going on with the patient, because subspecialists notes typically tend to be more focused. So if an oncologist is doing a consult, their history of present illness might be focused on anything that has to do with why they are consulted, but also their assessment and plan will be focused on why are they consulted. They might just mention the other things that are going on with the patient, but not necessarily get into its management or comment on it, because that's not the reason why they are on the case. Now, on the when you're and this would be clear in every consultant's note. So when the primary internal medicine team is writing a note, if the resident is doing a pulmonary critical care rotation and is now the pulmonary resident, their note will be focused on the COPD or the asthma exacerbation or whatever is the cause, that the reason why they are getting consulted. Now, and that has to be also clear to the primary team. What is the thought process that is going through the minds of the specialists, and what are they thinking? It's not always the case in, for example, a hematologic disorder that the hematologist is consulted for a thrombocytopenia, that we know right away what's the cause, but at least know what are they narrowing it down to, what are the possibilities, what workup they need, and what parameters do you have for this problem that they want the patient to be transfused to, up to, for example, if a patient has thrombocytopenia. So it's a specialist-driven conversation. Now, sometimes in specialties that are primary, like my specialty in bone marrow transplant, we play both roles. So we are most details in our assessment and plan in the primary reason why we admit our patients, because we are the primary in the hospital. We take care of our own transplant patients. So we admit them for an allo transplant. So we are detailed in that, but we also manage all the other things. So we are internal medicine on, with a touch of critical care, but actually an oncologist in the note, and that's one way that we, and that's another way of when you are a consultant, when you are a subspecialist who's running as primary. You sometimes would consult internal medicine or endocrine to manage if the diabetes is poorly controlled or needs more management, because it's becoming too much insulin being given, and it might need a better control than that, or a joint that needs to be tapped, or a fib that is not controlled with the standard interventions that we do, or a possible non-STEMI on a patient who just had a recent transplant. So your SOAP note should always be focused on what your role is in the patient's care. And as you all clearly stated, it's a process that you need to update all these sections that you have covered very well. But then when you're a subspecialist, you're just talking about what the reason why you're involved. So just a quick story. When I was a resident, before doing internal medicine, and when I was in med school, I had interest in ophthalmology. So when I had a case when I was a resident and I was on CCU, there was something going on with the patient's eye. So I commented on it in the assessment plan, and the cardiologist just flat out crossed it off. Like, because that's not part of what you are supposed to do. You're not supposed to be on CCU and as the cardiology, the resident on cardiology, and comment on things that are unrelated to why you are. If that's something that needs a specialist, you bring the specialist to do what's needed. So it's important to keep in mind those things as you throughout your training will learn different ways of doing the exact same note, and eventually you will have your own way of doing it. And that's I believe the most important message out of this talk. And again, thank you guys very much. And I don't know if there's anybody has questions.
Thank you, Dr. Hamza. Thank you so much for being with us. So guys, I will share this presentation on YouTube, and the data itself, the presentation itself in PowerPoint will be on the ABCDE group if you want to join and see this presentation. And for now, if you have any question, you can just type it in the chat, or you can just unmute yourself and ask whatever you want. If you have any question for Rafiq or Dr. Muafi or Dr. Hijazi, it will be okay. We have less than 20 minutes if you have any questions. Anyone has any questions about help notes?
Okay,
Go
I
on.
have a question for Dr. Rafiq.
Mhm.
Regarding the difference between systems between Egypt and the US. Did doing your residency in Egypt advance or harden your skills, or wasn't it worth it and start from scratch in the US?
Yeah, okay, I can't get what he say. So like in terms of notes and progress notes and H&Ps, that's completely different because we don't do this really much in Egypt. I mean, in terms of EMR. But if your question is mainly about like as a clinical experience, obviously it never hurts. Like it can show up. Like I've been told that it shows to my attendings, to whoever I'm being supervised by, that well, it seems that you have a previous experience, and well, it never hurts that you have been exposed to medical practice in your home country before coming to the US, though it's completely different, as you can tell. But in the terms of worthiness, I can't really comment on that because it really differs on what kind of a specialty you're doing, what's your career plans, and your home country, what are your plans to come over here to the US. But I would definitely say if someone is doing something like in direct patient care in his home country, it's not just waste of time. It can really give you a strong clinical background, and it can show up when you come over here, because it's at the end of the day, it's the same medicine. It's a different way of approach, but same medicine. But it can still give you a strong background when you come practice over here. In terms of, again, I mean, in terms of worthiness or how long you should spend in your home country before coming to here, it's really something different from one story to another. I can't really get into detail in this aspect, but I would say again, it really helps when you come over here, because it would show up like you've learned a lot of clinical skills, dealing with your peers, dealing with your attendings, even in Egypt. It will still have the same kind of experience over here, if this is answer your question.
Thank you, Dr. Rafiq. Any other questions, guys? You can type it into the chat board, or you can just unmute if you have any other questions. Anyone?
Hello.
Hi.
Thank you for this presentation. It is really helpful. I have a question regarding if I want to practice and to learn more to improve my skills in writing notes, patient notes in American style. Do you recommend any book or software that can help me? Thank you.
I don't know who can ask this question. Can you, for Dr. Rafiq or Dr. Mafi or Dr. Hijazi, anyone has any? She's asking how can she prepare for this, or if there any other platform or something she can read which can help her.
Honestly, I wish I could help, but I don't really know of any platforms. I just.
Yes, same here. I'm not sure if there's a specific platform that you can read or learn about typing the notes in the US. But what I can say in this, that if you're doing a rotation here in the US, doing research anywhere, you are exposed to the EMR. It doesn't matter if it's Cerner, Epic, whatever kind of EMR. You can spend time reading your residents' notes, your physicians. This would actually give you a lot of experience just by reading a lot. But this might be some other materials to use, but I have no idea about that, unfortunately.
I think I have something to add here. Thank you, Sir Rafi. So reading, this is the first thing. I've tried to break some cases or some examples, like you asked it to give an example to you, and it's really hard to do this because it's illegal somehow. It's not that accessible, but I know some applicants from Egypt and other countries who didn't take CS, so they are not familiar with even typing. So this is the earliest step you can develop. There is a lot of platforms or application you can use to develop your typing speed, typing skills, and go through this presentation and other presentation explaining how to write HPI, how to write this stuff. You can just I suggest you can, after training with this speed type, you can just, okay, I will try to do HPI right now. And if you have a patient with you in your hospital in Egypt or you're training in Egypt, you can just try to make it in this style, and you can have someone from us from here can help you to review it. I think it will help. I think about this question before, and I was about to ask you about this. So thank you for the question. And this is something to consider. Try to work on your writing experience writing speed. And that's it for me. Dr. Hijazi, do you have anything to add?
I think the reality here is you don't get the real experience until you do a rotation, like Rafiq was saying. Of course, during the rotation, you have the experience, and then you will have to, if you're typing, you need to type fast, like Mustafa was saying, that being quick with that, but not necessarily you have to be the fastest, because you need to know what you need to type, and then typing become the easier part, because if you know what you need, it might then translate into your typing. But improving the typing skill is important, so you can save yourself time, because well, recently there was a survey among physicians here in the United States asking how much time do they spend documenting out of their hours in working hours, and the majority, we're talking about more than 40% of the time is being spent in documenting rather than actual talking to the patient or putting orders that helps the patient or such. So yeah, being fast, but knowing what you need to do would ideally be by interacting with the system. Coming early as a student to the United States is important, to do rotations or electives, so you can learn it early before you see other ways of doing it, or the systems that don't use much of that type of documentation. But I'm sure looking online, you will find articles, videos, and things about how do you write a SOAP note, how do you write a consult note, how do you write an HMP, and such. And that might give you an idea, but eventually, remember that when you come into the system, it depends on where you are in the system. You are going to learn from your senior or from your attending. So it's going to be their style. They might actually enforce a change But it's good to be ready. Like the reason why you're asking, you want to be ready. So it's good to be ready and come with a with some idea of how it's written, so it's not completely brand new to you. But the best advice would be, if you want to know the system before you are a resident and you're is expected to write these notes and do it appropriately, is to get involved with it beforehand, doing rotations. That's my answer.
Thank you, Dr. Hijazi. We still have more seven minutes. Do you have any more questions? Okay.
Is it possible to ask an unrelated question?
Unrelated to SOAP notes or unrelated to residency?
Yeah, notes.
Okay, I think it's okay. If no one else has any question, you can ask.
My question is for Dr. Mouafi. Could you please point out the 1-year research program you did? Was it part of the licensing or just a diploma?
If you're asking about my research experience, yeah, I was doing clinical research with Mustafa and Rafiq at University of Louisville. I was doing it in the Department of Infectious Disease. It was just a research internship, essentially. I didn't spend there a long time. I just spent 10 months there. Then I went off to start my residency. But yeah, that was it.
Okay, thanks.
Any other questions, guys?
I can add something real quick on Mustafa.
Yeah.
Something that I've, as an intern, I'm learning. Sometimes when we go like to see my patient, okay, is this patient again COPD exacerbation? Okay, it's easy. Let's start him in whatever inhalers, steroids, and you just focus on the COPD exacerbation. But as Mouafi was saying, you're still an internist, so you're not here the palm crit specialist dealing with COPD exacerbation. You need to dig in a lot and see, is the patient diabetic? Is the patient having hypertensive? What's his other comorbidities? Hyponatremia, mildly elevated troponin levels. His LFTs looks slightly abnormal. You need to look up into these, and you have to mention those in your notes. So, like something I've been like one of my seniors told me about that as an intern, you need to have don't just like put 1 or 2 problems on your assessment plan. You need to have like a good number of problems in your note. You're not just managing the COPD exacerbation. That's just stressing on what Mouafi was saying. You need to see any other abnormality going on, and you need to deal with this, because you don't know what would happen. Maybe in the next day, patient may deteriorate or decompensate for any other reason other than the main problem he's been admitted for. So just that's a piece of advice I think would help a lot of interns getting into the match next year.
Thank you, Dr. Rafiq. I see someone's raising the hand. Amir, you can go, Amir. Dr. Amir. So he's asking in the chat, excuse me, can you tell me what's the easiest way to find a research opportunity in USA for undergraduates? Okay. Anyone want to have this question, Rafiq?
I can go really quick. I'm not sure what you mean by undergraduates. You mean like you just graduated from medical school, or you're still in the medical school? I'm not sure what you mean about that. But if you mean like you just graduated from medical school and want to look for, you say still in medical school.
He didn't graduate. No.
Okay, so it might be still more tough for you to find because you still need to finish your medical school. Okay, 6th year. I think emailing a lot of institutions, getting in contact with other colleagues who have done research already, have other contacts, but maybe emailing different institutions, emailing attendings over here, just wrote in, sent tons of hundreds and hundreds of emails until you get a feedback.
I think he's 6th year, so he's planning to try to apply till he finishes the medical school and then go from there, I think so. So this is the answer, Amir. He is, Dr. Rafiq said, you should contact the universities and your colleagues here to get into any research position. And actually, this research will help you to see some more sub notes. Don't forget about them. It's very important. So I think this concludes our webinar today. If there are any other more questions, you can just email it to me or send it to and the page, ABCDE page on the Facebook, and I can get back to you. So thank you for Dr. Rafiq, thank you for Dr. Muafi, and big thank you for Dr. Hijazi for your time and your sharing the information with us. Thank you everyone for being with us today.
Thank you.
Thank you so much. Have a great day. Bye, everyone.
Thanks, guys.
Thank you.
It was a pleasure being here.
Thank you. Thank you.